Hello, good morning to my all medical students, newcomers, learner, perfusionists. How are you? Are you okay? Happy in a good mood? Today I'm going to talk about the hypothermia, deep hypothermia, and cerebral perfusion. So, cerebral perfusion, we have two type of cerebral perfusion. Antigrade cerebral perfusion and retrograde cerebral perfusions. The objective of my today's talk, of course, to discuss antigrade or cerebral perfusion and retrograde cerebral perfusion. Then we're going to describe the cerebral circuit during the bypass, types of cannula, flow dynamics, pressure dynamics, and we are going to identify the cannulation sites, how we're going to cannulate the patient, which type of circuit we have to need to design. So we'll try to highlight the small all point which we need to learn and which we need to discuss. So get set ready, be in a happy mood, and enjoy the topic and enjoy the session. So method for the cerebral protections, we can go through the direct cannulation of all three brachiocephalic arteries. We can arrest the heart by deep hypothermia by reducing the temperature, and we get a chance to stop all body circulations. And in the meantime, we can establish retrograde cerebral and antigrade cerebral perfusion of the brain. Hope it is clear. So first we're going to talk about the hypothermia. So during the bypass, we can decrease the body temperatures, and if you talk about the hypothermia is categorized in three types: mild, moderate, and severe, or we can deep. So mild temperature is from 32 to 34. So we can say drift. The normal temperature of the body is 37. If it decrease 36, 35, we can use the term drift. We drifted the temperature. If you are maintaining temperature 32 to 34 during the bypass, it's you did a mild hypothermia of the body. If your temperature of the body, of the blood, is 25 to 30 degrees Celsius, this is moderate hypothermia. Deep hypothermia, if your temperature is 20 or below than the 20, and especially if your temperature of the body is 18 degrees Celsius, your core temperature, so you will get a safe 45 minutes to stop whole body circulations. And meantime, surgeon can work on the part where it's difficult during the bypass to do the work. So some of the procedure where we require to stop whole body circulations, and the point come up that by stopping your whole body circulations, how will you going to protect the brain? So during the deep hypothermia, we always prefer to perform cerebral perfusion of the brain. How it can be technique retrograde, or either it can be antigrades. So we'll today going to talk about the retrograde cerebral perfusion, or we can say RCP. This technique was introduced in 1980 by Mills and Ochsner, and this was normally using as an intermittent to remove the massive air from the brain and the body. And in era of the 1982, this intermittent RCP used for repair of the proximal aortic dissection, normally they are using. And the later in 1990, the continuous RCP, mean retrograde cerebral perfusion, introduced to which shows us the result by doing continuous retrograde cerebral perfusions, the outcome of the patients come better. So this is the old technique which was used by the team to protect the brain, or by removing the air from the part of the brain. So what's the advantages in the short terms? We can say this is a homogeneous cerebral cooling. We can cool the brains, wash out of the air bubbles, embolic debris and the metabolic waste products was removed. At the same time, the delivery of the oxygen for the neutral substance to the brain tissues, and it is reducing the cerebral ischemia during the bypass. What was the ideal flow for the retrograde is 25 to 35, or the maximum you can achieve is till 45 millimeter per mercury during the bypass. Flow from 200 till 500 mils per minute you can run pump for retrograde perfusions. So it depends on how much you are maintaining this. So ideal mean pressure is 35 millimeter, but from 25 to 45 is the safe range to maintaining the retrograde cerebral perfusion pressure. The ideal and safe flow is around 200 to 500 mils per minute. So in case if you are doing the bypass and your aortic canal is cannulate in ascending aorta, and you need to do your retrograde cerebral perfusions, then this time you have to remove your antigrade aortic cannula from ascending aorta. Here I can just mention we have two type of circuits which I know. So of course different perfusions have their different technique and the way they can maintain the cerebral antigrade retrograde perfusion. So according to me, if you want to perform retrograde cerebral perfusions, so the circuit A is if you are cannulating SVC, IVC for drainage, and for your return is femoral artery example. So what you can do, you can use an extra pump which going to be connected with your from the reservoir outlet which is going to the pumps. You make it bifurcation, so one outlet is going to a separate pump, and through that hook the tube to the SVC. So in case you are going to stop your whole body circulations, you can maintain the retrograde cerebral perfusion from femoral artery to direct to the SVC, and the rest of the body will be stopped and there will be no circulation. So this is the circuit A. But if you are doing the bypass with the ascending aorta cannulations and from SVC IVC drainage, so you have to remove your aortic cannula, and you can generate your drainage through the IVC and return back your drainage to SVC. This is one method. This is the method B, where you can perform your retrograde cerebral perfusion. Hope it is clear. Now will come up the technique which is commonly used nowadays is the antigrade cerebral perfusion. So retrograde means the opposite of the normal flow phenomena. Antigrade means the same which is normal physiology we have to perform the normal flow phenomena circulation. So antigrade cerebral perfusion is the selective cannulation of the arteries to maintain the cerebral flow. So it's up to the procedures. Either you want to brachiocephalic or specific any arteries, like if you need to cannulate right subclavian or right common carotid or left common carotid or the left vertebral artery or left subclavian artery. It depends which type of the procedure is this. So it will going to be decided by your surgeon, not by the perfusionist. Okay. So selective cannulation of the arch arteries to maintain the cerebral flow. We can use CPDS means we can use even the cardioplegia delivery systems as to maintaining the antigrade cerebral perfusions. So there is one method also, and bifurcation of the aortic line or can be used auxiliary approach. So for maintaining the cerebral perfusions, ideally what we are using the same circuit which was going to use for cardioplegia in cardioplegia delivery system. And when your surgeon cannulated your any artery which is arising from the aorta to the brain, and that plegia line was going to hooked So now without potassiums you can run your antigrade cerebral perfusion to the brain, and how much flow you require for that is around 10 to 20 mils per kg per minute is the idea. For example, if your patient's weight is 70 kilograms, so antigrade perfusion can be ideally 700 mils. Some of the studies shows that 30 mils, 50 mils even per kg per mils, but the ideal is keep it like a 10 to 20 mils per kg per minute, the flow rate of antigrade cerebral perfusion. The pressures ranges is around 80 to 100 millimeter per mercury. So the time you are perfusing the brain, your pump pressures should be in the range of 80 to 100 millimeter per mercury, and your pump flow is the range of 10 to 20 ml per kg per minute the flow. Hope it is clear. Now we'll talk about our current strategy of the as I mentioned, either you need to cannulate the axillary brachiocephalic arteries, or either you have to cannulate carotid, subclavian, or there is another way. The other way is normally the time of to initiate bypass, instead of cannulating ascending aorta or the femoral, surgeon used to cannulate axillary with the graft. So the same cannula which is using for your routine bypass, the same cannula can be used as an antigrade cerebral perfusion. So our current strategy of the atrial perfusion is the right axillary artery perfusion with the 8 millimeter of the prosthetic graft in a repair of ascending aortic arch dissection. So selective antigrade cerebral perfusion cannula, if you are going to cannulate subclavian artery or carotid artery, so ideal is you can use your retrograde cannula which is available, or either you can use the 12 French, any other cannula. The ideal is you can use the retrograde cannula, which is going to help to cannulate your either subclavian or carotid, and it is fixed there, so you can use that. You can perfuse the cold cerebral to adjust the 10 to, as I mentioned, 10 to 20 mils per kg per minute the flow, but it should be less than liter. Your antigrade should not go more than the liter per minute. So it's up to what was your weight of the patient's body weight, and according to that you can flow and maintain the pressure of antigrade cerebral perfusion. For the ascending aorta cannulation, we have one third method also. So we can do like axillary aorta to fem artery, or SVC IVCU to RA. So different people have their different techniques. They establish their antigrade or retrograde flow. Hope I'll try to explain much as I know, and the chapter is still open, discussion is still open, and so many people have their more expertise in the field of the perfusion. So hope the point is clear, what is antigrade and what is retrograde, and what is going to help with the antigrade and what is going to help with the retrograde. The depth of the temperature ideal for the long surgery like dissections, 18 degrees Celsius, where you get a 45 minutes cure, and the meantime you can do the intermittent or continuous antigrade cerebral perfusion or retrograde cerebral perfusion. So hope it is clear. Have a nice and blessed day. Take care. God bless you.